Good morning, students. Today's topic of our lecture is physiology of labor, clinical picture and management of physiological labor, physiology of puerperal stage, and physiology of neonatal stage. First of all, what is labor or what is delivery? Is unconditioned reflex act is directed to expulsion of fetus from uterine cavity. Term of gestation must be not less than 22 weeks, body weight of fetus not less than 500 grams. Physiological delivery has spontaneous beginning and labor activity progress in low-risk group pregnant women at term of pregnancy from 37 till 42 beta 41 weeks. There are some theories of labor beginning. You can see that maybe different theories. It's immunological, humoral, oxytocin theory, nerves plexus compressing, placental, etc. Predominance of break processes in brain cortex and subcortical structures, irritability are present at the end of pregnancy and labor beginning. Spinal reflexes increase, reflex and muscular irritability are increased, estrogen's level increase and progesterone level decrease take place last 2 weeks of pregnancy, especially before labor. An important role of labor activity beginning have prostaglandins E2 and F2 alpha. They produced in decidual and fetal membranes. Their production increase before labor. Prostaglandins biosynthesis are activated by steroid hormones. So estrogen's level increase lead to prostaglandins level increase in uterus. Adrenal glands of fetus take place in this process. Prostaglandins induce labor by myometrium cells membranes depolarization that leads to calcium ions activation and contraction of myometrium. Besides that, prostaglandins stimulate oxytocin secretion and progesterone destruction. There are different mediator and hormonal receptors in myometrium, such as alpha-adrenal receptors, serotonin, and M-choline, histamine, estrogen, progesterone, prostaglandin receptors. There are E2 receptors in cervix and F2 alpha receptors in corpus of uterus or body of the uterus. Sensitivity of uterine receptors depends on hormonal homeostasis, mainly on correlation of sex steroid hormones, estrogens and progesterone. Level of estrogens is in direct dependence of functional state of fetus and placenta. So fetus renders determining influence on active estrogens level in placenta and mother's blood. Normal labor activity takes place on a background of optimal maintenance of estrogens and formation of enough active receptors in uterus. You can see different mechanisms of estrogen's action. It's cervix preparation for labor. It's instrumental in alpha adrenal receptors formation on the surface of myocytes, which react on oxytocinic and bioactive matters. Promote activity of phospholipase. Those lead to lysosomal membranes destabilization and free and activate prostaglandins E2 and F2 alpha from arachidonic acid. Next action, its synthesis of contractive proteins in myometrium increase such as another matters are necessary for energy of uterine contraction synthesis. Permeability of cellular membranes increase for ions, which increase myometrial cells' sensitivity to irritation. Increase of speed and intensity of biochemical reaction, and increase of bloodstream and circulation of blood in myometrium, oxygen use, power providing of uterus. Estrogens promote and structural changes of cervix, myometrium preparation for uterine pacemaker formation, and synchronization of contractions in uterus. An important precondition of normal course of labor is maturation of cervix, which we check according Bishop's score. Tissue of cervix undergoes to hydration to make it friable, destruction of connections in collagen fibers. Maturation of cervix is complex bio and histochemical process of change collagen properties. The main components of this process are hydration, making collagen net friable with collagen concentration decreased, destabilization of connections between different fibers, change of structure and concentration of proteoglycans, change of mechanical properties of cervix. Time for cervix preparation to labor makes on the average 8 to 14 days. High level of estrogens and prostaglandins E2 that promote collagen distension have influenced the process of cervical maturation. Processes of cervix and myometrium preparation to labor normally take place synchronously, and structural changes of cervix usually finish to 38 to 40th week of pregnancy. Mature cervix has following characteristics. I repeat again, we check it according Bishop's score. It's present in literature in your books. It is located on the pelvic axis. An external os is located on the level of a spinal line. It is shortened to 1.5 to 2 centimeters. It is fully softened. An internal os is soft, fluently passed to lower segment. Cervical canal is 2-3 centimeter dilated. Length of vaginal part of cervix correspond to length of cervical canal. Fetus accepts optimal flexile position under the action of preparatory contractions of uterus till the end of pregnancy. Head of fetus fixes densely or disposed in a pelvic inlet by a small segment. Sagittal suture sets in an oblique or transverse diameter, small fontanelle under the pubic symphysis. All that will promote more easy passage of the fetus in future. Preparative contraction of uterus are characterized by not only structural changes of cervix and by complete painlessness, big interval between separate uterine contraction, might continue some hours and even some days. And again, later I show additional information about it. Level of serotonin, which promote retractive activity of myometrium, increase during preparative pre-labor period. Level of oxytocin, which stimulate frequency and amplitude of birth pain and promotes tone of uterus, increase till the end of pregnancy at enough estrogen saturation. Prostaglandins and oxytocin are synergists. Normal preparative pre-labor period, or another name preliminary period, is characterized by the followed sign, another names such as precursors of labor. First of all, uterine fundus goes down on a few centimeters due to amount of amniotic waters decrease. Presenting part of fetus is densely fixed in the pelvic inlet in first plane. Cervix becomes soft, elastic. Mucoserous discharge appear from birth canal. Labor happen formation of labor dominant, and tissues of birth canal are satiated by estrogens maximally. Next, excitability of uterus increases. The precursor of labor pains appear, spontaneous contractions of uterus. Body weight of pregnant goes down on 800 till 1000 gram 5-7 days before labor. Sympathetic and adrenal system activity increase, force of uterine contractions increase, and separation of fetal membranes on lower pole of amniotic sac from uterine wall takes place. Those lead to intensive synthesis of prostaglandins. And what are Braxton Hicks? Another name is practice contraction. After months of relative inactivity during pregnancy, the uterus contracts more and more often in the weeks before birth. Ascensional uterine contractions have taken place throughout pregnancy, but they have been so sporadic and weak that they have had no effect on the cervix. Contractions during last weeks of pregnancy irregular but they are more frequent and coordinated than early ones. These contractions were first described by an English doctor named Johnson Braxton Hicks. If Braxton Hicks contraction increase and become rhythmic late in the pregnancy, they are referred to as false labor. And later I show differences between false and true labor. You can see and present some answers on some questions, such as how often do their contraction occur? Do they change with movement? How strong are they? Where do you feel the pain? And you see what answers in case false labor and in case true labor, and what differences. Diagnostics and confirmation of labor. After 37 weeks, spastic pains at the low region of abdomen and sacrum with mucus discharge from vagina. Another name is mucus plug. Mucus plug present because happen effacement of cervix, maturation of cervix, and cervical canal dilate, and this mucus comes out from the cervical canal. Not less than one birth pain by duration 15 to 20 seconds per 10 minutes. Change of shape and disposition of cervix, dilation of cervix, and gradual descending of fetal head to pelvic inlet. A delivery act is a process of cooperation of three components: labor forces, birth canal, and fetus. A process of physiological labor includes main components: development of automatic regular contractive activity of uterus, changes of structure of cervix, distension of low segment. And formation of contraction ring. And you see that high of contraction ring, it's border between body and isthmus. A high of contraction ring above pubic symphysis usually correspond to degree of cervical dilation. Gradual dilatation of an internal os until complete dilatation 10 centimeters. Passage of fetus on a birth canal and his delivery. And another component, placenta separation and afterbirth. Afterbirth, such as you know, consists from placenta plus umbilical cord plus membrane. And of course, must be expulsion of after birth. According previous information, I repeat again and pay you attention that all process of labor consist from 3 stages. First stage is dilatation of cervix. It starts from the beginning of regular birth activity and finishes by complete dilatation of cervix. Complete dilatation is 10 centimeters. Second stage is expulsion of fetus, starts from complete dilatation of cervix when labor portion appears and finishes by expulsion or extraction of fetus. And third stage of labor is stage of placenta separation and after birth expulsion, starts from birth of fetus and finishes by complete expulsion of afterbirth. In average time of physiological labor, it's from 8 till 12 hours, especially if it's primipara, and if multipara, usually duration from 6 to 8 hours. Labor forces are complex physiological process are regulated by nerves and humoral veins. Uterus is innervated by sympathetic and parasympathetic nerves. The main sympathetic mediators are, such as it's noradrenaline and adrenaline. A physiological effect of catecholamines takes place by their action through 2 types of adrenal receptors, alpha and beta. At excitation of alpha adrenal receptors, contraction of uterus happens. At excitation of beta adrenal receptors, breaking of contractive uterine function. At physiological course of labor, contraction of uterine muscles take place under the action of acetylcholine. In future, there is destruction of acetylcholine by a cholinesterase that leads to gradual wave of contraction falling. Next contraction of uterus arises up at appearance of new portion of acetylcholine. Wave of contraction of birth pain begins in one of uterine corners. It's named pacemaker and spreads with decreasing force downward to low segment and cervix of uterus. Later I show it on picture. Speed of uterine contraction spread is 2-5 cm per second. After 15 to 20 second contraction engulf all uterus. Pacemaker usually is located in place opposite to placenta location, most commonly. Besides that, it can migrate, displace to body, lower segment of uterus that lead to pathology of contractive activity of uterus and abnormal birth pains. Pacemaker is not anatomical but physiological conception. Such as you see, present review of normal uterine action. Its regular interval gradually shortens, intensity gradually increases, discomfort in the back and abdomen associated with cervical dilation and discomfort not relieved by sedation. And this slide you see characteristics, you can see characteristics of the power of the uterine contraction. Greater intensity in the fundus, in average intensity of contraction 24, but beta more millimeter, beta if it's until 60. Well synchronized frequency, duration 60 seconds. It must be regular rhythm and force, and basal resting pressure from 12 to 15 millimeter if we use hysterography. Uterine contractions start in fundus of the uterus, and spread from top to down, from upper to down parts to low parts of the uterus, with decreasing strength. Superior parts of uterus contract more strong than lower regions that lead to tractions of cervical muscle fibers up. Amplitude of contraction of fundus 3 times more than lower segment. That phenomenon is named triple descending gradient. Duration of contraction diminished according to retire from the fundus of uterus to low segment. Review of normal uterine contraction polarity of uterus. When upper segment contract, lower segment relaxed. It's distraction. Later I show it. Pacemakers. 2 pacemakers situated at each corners of uterus generating the contraction is in coordinated manner. Pattern of contraction. Uterine contraction start at corners, propagates towards lower uterine segment with decrease in the duration and intensity of contraction as it moves away from pacemaker. Uterine contractions in labor have coordinated character that is regulated by the autonomous nervous system. Under the action of mediators of autonomous nervous system, prostaglandins, E2, F2 alpha, oxytocin, and other bioactive matters which act in alpha adrenal receptors, contraction of all longitudinally located smooth fibers takes place. Processes of retraction and contraction. Active relaxation of smooth fibers have circular direction takes place at the same time, which determines distraction of low segment and cervix of uterus. Uterine contraction continues or systole of birth pain continues to diastole or relaxation. A diastole is usually longer than systole of birth pain. Relaxation always longer than contraction of the uterus. You can see what changes happen in muscle fibers during contraction. On the peak of contraction, length of muscle fiber less, but increase thickness of them. And such as result of contraction of upper parts of the uterus, such as result of contraction of longitudinal and oblique muscles, happen relaxation and distraction, happen stretching of the circular muscles which located into the low segment and cervix of the uterus. Again, you can see how change upper muscles, increase thickness of these muscles, and happen stretching of the muscles in the low segment. If beta contraction in upper parts of the uterus, beta dilation of cervix. Cervix never dilate if absent normal uterine contractions. Frequency of birth pains is determined by number of uterine contractions per 10 minutes. Frequency of birth pains in case of normal labor is 3 to 5 per 10 minutes. During first 4-5 hours of labor, main structural changes of cervix take place. After smoothing and 3-4 cm dilatation of cervix, active phase of labor starts. Speed of dilatation of cervix increase 1.5-2 times. Speed of fetus passage increase 2. There are two phases in first stage of labor. First phase is latent phase, start from appearance of regular birth pains and finishes by 3 centimeters dilatation of cervix. Its duration is about 4-5 hours, maximum 8 hours. Birth pains are painless or a little painful. Woman is quiet. Speed of dilatation of cervix is 0.35 centimeter per hour. After 3 centimeter dilatation and proceeds to complete dilatation of cervix, second or active phase of labor starts. It is characterized by active labor activity and rapid dilatation of uterine os. Mean time of this phase is 3-4 hours, sometimes more. Speed of dilatation of cervix is 1.5 to 2 centimeters per hour in primipara and 2.5 centimeter per hour in multipara, but usually it must be not less than 1 centimeter per hour. After amniotic water outflow, in active phase labor activity increase. It's happened because increased level of endogenic prostaglandins. How happen dilatation of cervix in primipara? If it's primipara, first of all happen dilation of internal os. Only after that start dilatation of external os. If it's multipara, secondipara or multipara, both oses, they are open together. In same time happen dilation and internal and external oses. And of course dilation of cervix happen faster. At this picture you can see that happen formation of amniotic sac. You can see such as baby engage, fetus engage into the plain inlet. If labor happen in accipita anterior presentation, engagement diameter is subaccipita brygamaticus, and baby engaged in the plain inlet and happen and divide all amniotic membranes on anterior part and posterior part, and anterior part of amniotic membranes and anterior amniotic water named such as amniotic sac. During during labor pain, increase intrauterine pressure, and it's additionally help for dilation of cervix in active phase of in latent and active phase of first stage of labor. Since moment of complete dilatation of cervix, second stage of labor starts, or fetus stage named fetus expulsion. It ends by fetus birth. In the second stage of labor, head of fetus pass broad and narrow parts of pelvic cavity and descent on a pelvic floor. Duration of second stage of labor is 30 to 60 minutes, but maximum it's 2 hours in primipara and in average 15 to 30 minutes in multipara. But again, maximum, I repeat again, maximum duration of second stage of labor is 2 hours. In the aid of second stage of labor, when presented part irritates receptors of inferior part of vagina and of pelvic floor, labor pushing or contraction of skeleton muscles and diaphragm appear additionally to labor pains. Look, happen contraction and uterine contraction and contraction of anterior abdominal muscles. Forward movements of fetus take place on an axis of birth canal. Presenting part do some adaptive movements. In case of well-coordinated labor activity, physiological course of labor fetus does not suffer during labor pains. Frequency of fetal palpitation does not change strongly. Principles of normal labor conduct to estimate degree of risk of maternal and perinatal pathology development, to determine a plan of the labor conduct, and to receive an informed agreement of women, to control mothers and fetus condition during labor with patagram use. Later I show it. If necessary, we use anesthetics to estimate condition of fetus after birth, primary conduct of newborn, and early breastfeeding. Medical supervision in first stage of labor or management of first stage of labor. It's estimation of fetus condition. Of course, we check frequency of heartbeat of fetus per 1 minute, every 15 minutes during active phase and every 5 minutes during second stage of labor. Next, estimation of mother's condition. We measure body temperature every 4 hours, parameters of pulse and blood pressure every 2 hours, diuresis every 4 hours. Additionally, we check level of acetonuria or proteinuria if necessary. Estimation of labor activity effectiveness, frequency, duration, and intensity of birth pains, every 1 hour in latent phase and every 30 minutes in active phase. By manual or internal obstetrical examination, minimum every 4 hours. If necessary, interval less, if develop some abnormalities of labor activity. Additionally, we palpate position of fetal presenting part during every external and internal obstetrical examination. If rupture of amniotic sac has happened, control of color, consistency, and amount of amniotic waters. At this picture, you can see different poses which we propose for patients for psychoprophylaxis, for reduce pain during first stage of labor. And patients choose more comfortable position for them. What is management in second stage of labor? Women may choose the most comfortable position in second stage of labor too. Estimation of general state of woman, her hemodynamic indexes such as blood pressure, pulse every 10 minutes. Of course, we check fetal condition, control of heartbeats every 5 minutes, or if present indication, if necessary, we check it after every labor pain. Passage of fetal head through birth canal. We check descendants of the fetal head. Amniotomy should be done in indication if it's not if rupture of amniotic membranes not happened before. Delivery of head of fetus needs for gentle obstetrical manual aid, protection of perineum. But today it's not recommended. Today we don't use obstetrical manual protection of perineum. It's not recommended. It's excluded for normal management of labor. I pay you attention on it. What documents necessary prepare during labor? The main document of labor is pathogram. Pathogram is a graphical information about the progress of labor, in which the salient information about the fetal well-being, maternal well-being, and the progress of labor are recorded into a chart. In pathogram, you see that present two phases. Picture divide on two parts. It's latent phase and active phase. I repeat again, latent phase finished when cervical dilation 3 centimeters, and after 3 centimeters of dilation start active phase. In the part of active phase, introduce the concept of alert and action lines. Alert line represent the mean rate of slowest progress of labor, and action line, appropriate action should be taken. Normal labor is plotted to the left alert line, In pathogram, present first of all mother information, name, surname, gravidity, how many pregnancies, how many labors, date and term when she hospitalized in labor room, and time when happened rupture of amniotic membranes, if it's happened before. Another part is fetal well-being. We check fetal heart rate. I repeat that in first stage of labor we must do it every 15 minutes. Next parameter is character of liquor or amniotic fluid. At this example you can see letter C, it's clear. Sometimes maybe letter I, it's intact amniotic membranes. Maybe letter B, it's blood in amniotic fluid. Letter M, it's meconium, or maybe letter A is if amniotic fluid absent. And next it's molding. Next line it's molding. It's maybe 0, maybe 1, 2 or 3 pluses. Another part of pathogram, it's labor progress. It's dilatation of cervix. You can see it's from 0 to 10. Next, it's descent of presenting part. It's maybe 5/5, 4/5, 3/5, 2/5, and 1/5. And another part, it's uterine contraction. Dark color, if dark color, we know that this situation, duration of labor pains more than 40 seconds. We must check activity of uterine contraction every 30 minutes. At this part of pathogram, we have information about different medication. At these two lines, if necessary, use labor stimulation and we use oxytocin. At this line we write how many doses, how many units of oxytocin we use, and at another line we what rate of infusion, how many drops per minute. At this part some another medication, for example pain relief, if some antibiotics, hypertensive medication or other. And last part of pathogram, it's maternal well-being. We write information, we will write information about mother. It's BP, systolic, diastolic. These points, it's pulse. And this line is temperature every 2 hours, and information about urination and about urine output, how many milliliters, and level of albumin or glucose or acetone. Analyzing of the progress of labor from the pathogram. If progress is satisfactory, the plotting will remain on or to the left of the alert line, such as I said before. If labor is not progressing normally, the plotting will be to the right of the alert line, and sometimes it will near action line or behind action line. Of course, at this situation, we said about abnormal character of labor. Now we will discuss about third stage of labor. It begins after expulsion of the fetus and ends with expulsion of the placenta and membranes after birth. Altogether, placenta plus membranes plus part of umbilical cord named after birth. Third stage includes separation, descent and expulsion of the placenta with its membranes. Its average duration is about 15 minutes in both primigravida and multipara. Maximum 30 minutes, not depend, it's primi or multipara. The duration is, however, reduced to 5 minutes in active management. Before management, we will discuss about types of separation. It may be central or marginal. Both of them, they are physiological types of separation. But what is it? Central separation or Schultz separation is detachment of placenta from its uterine attachment start at the center, resulting in opening up of few uterine sinuses and accumulation of blood behind the placenta, with formation of retroplacental hematoma. With increasing contraction, more and more detachment occurs, facilitated by weight of the placenta and retroplacental blood until whole of the placenta gets detached. And when happen expulsion, at this situation, we can see fetal part of placenta. Marginal separation or Duncan separation start at the margin as it is mostly unsupported. With progressive uterine contraction, more and more areas of placenta get separated. Marginal separation is found more frequently. And when placenta delivery, we can see both parts, and maternal and fetal part of placenta. I like this table. It's scheme of management of third stage of labor. According to this information, you see that present expectant and active management. I want to pay attention that in active management we use injection of oxytocin, 10 international units, or injection of methylergometrin to the mother within 1 minute of delivery of the baby. After that, clamp, divide and ligate the cord. To deliver the placenta by controlled contraction soon after the delivery of the baby, availing first uterine contraction. But I must say that by one hand we use traction of the umbilical cord, by another hand we use contraction of the uterus for prevent insertion of the uterus. And we repeat after 2-3 minutes again repeat tractions. And you can see what our action if it's difficult. Now I want to explain passive management or expectant management. At this situation, detachment of placenta happens spontaneously. At this situation, we wait and watch. But first of all, we are catheterize the bladder if needed, and we wait signs of placental separation. We wait for spontaneous separation of placenta. Later, I show more information about expectant management or about passive management. Of course, we wait when placenta detach. How we will know it's detached or not? For it presents some signs of placental separation. First of all, it's Schroeder sign. It's changing the shape and height of the uterine fundus. Immediately after the birth, the uterus takes a rounded shape and is located along the midline. The fundus of the uterus is at the level of the navel. After separation of the placenta, the uterus stretches, deviates to the right side, and its fundus rises to the right hypochondrium. Another is Alfeld sign, the descending of the external part of the umbilical cord, thus it becomes more than 10 to 12 centimeter in length. If it's happened, if placenta separated from the uterine wall. It's positive Alfeld sign. Another sign, it's Kussner-Tchoukalov sign, pressing down the symphysis pubis with the palm result in protruding of the external umbilical cord. If the cord is not protruded or becomes shorter, it means that the placenta has not separated yet. At this situation, we said about negative Tchoukalov sign. Another sign is Davzhenka sign. A woman is offered to breathe deeply. If the umbilical cord doesn't retract back into the vagina when exhaling, then the placenta has separated. It's positive Davzhenka sign. Another Mikulich-Radetzky sign, low abdominal bulge. Placenta separates and is situated in the lower segment, and the woman reflectively wants to push because happen irritation of nerve plexus because placenta descend in the low part of the uterus and or in the vagina. After the separation of the placenta, it will be expelled easily. Only when the features of the placental separation are confirmed, the patient is asked to make an effort like during the fetal birth. If the spontaneous expulsion fails, any one of the following methods can be used. First method is Abuladze's method, holding of the anterior abdominal wall with two hands and asking the patient to make an effort. The separated afterbirth is born due to an increase in intra-abdominal pressure. We don't touch uterus. At this situation, patient push, but we are decrease intra-abdominal pressure by holding of the anterior abdominal muscles. Another method is Henter's method. The fundus of the uterus lead to the midline. The doctor is on the side of the patient facing her feet. The hands press the fundus on the uterus in the area of its corners with two fists, gradually press in downwards and inward. A woman should not push before manipulation, necessary catheterization of the urinary bladder if it not used before. And last method is Creed's method, used only after unsuccessful application of other methods. The fundus is pushed downwards and backwards along the pelvic axis after placing 4 fingers behind the fundus and the thumb in front of the uterus. The pressure must be given only when the uterus becomes hot, when uterus contracts. A woman should not push, and before manipulation, same, necessary catheterization of urinary bladder. As soon as the placenta passes through the introitus, it is grasped by the hands and twisted round and round with gentle traction so that the membranes are stripped intact. Immediately after the birth of the afterbirth, it is necessary to examine it to make sure that the placenta and membranes are intact, because if not, it can provoke severe hemorrhage, because uterus cannot contract if it's not empty. Massage of uterine fundus through anterior abdominal wall and catheterization of urinary bladder, if necessary, should be used at once after afterbirth expulsion. 10 international units of oxytocin should be injected intramuscularly for hemorrhage prophylaxis. At absence of signs of placental separation and external bleeding during 30 minutes after childbirth, manual separation of placenta and removal of afterbirth must be done. Then the birth canal is examined to exclude, or if it's present, for suture of traumatic ruptures. And I pay you attention, normally blood loss, it's not more than 0.5% of body weight of patient or no more than 400 ml. If body weight of the patient 80 kg and more, normal blood loss not more than 400 milliliters. Now we are continue our lecture, and now we will discuss about physiology of puerperal stage. The puerperium is the period of time. Duration of this period continue until 6 weeks of pregnancy. In some literature, you find information that it continues before 8 weeks of pregnancy, but in average we say that duration of postpartum period is 40 days or 6 weeks. What changes happen in different organs and in vagina and vaginal outlet? Early in the puerperium, the vagina and its outlet form capacious, smooth-walled passage, then gradually diminishes in size but rarely returns to nulliparous dimensions. The hymen is represented by several small tugs of tissue. Vaginal epithelium begins to proliferate by 4 to 6 weeks, usually coincidental with resumed ovarian estrogen production. Lacerations or stretching of the perineum during delivery may result in relaxation of the vaginal outlet. Some damage to the pelvic floor may be inevitable, and parturition predisposes to uterine prolapse as well as urinary and anal incontinence. What happened in uterine vessels? The massively increased uterine blood flow necessary to maintain pregnancy is made possible by significant hypertrophy and remodeling of all pelvic vessels. After delivery, their caliber diminishes to approximately the size of the pre-pregnant state. Within the puerperal uterus, larger blood vessels become obliterated by hyaline changes, gradually resorbed and replaced by smaller ones. Minor vestiges of the larger vessels, however, may persist for years. Cervix and low uterine segment. During labor, the outer cervical margin, which corresponds to the external os, is usually lacerated, especially laterally. Not always, but sometimes it's possible. The cervical opening contracts slowly and for a few days immediately after labor readily admits 2 fingers. By the end of the first week, this opening narrows, the cervix thickness, and the cervical canal reforms. The external os doesn't completely resume its pre-gravid appearance. It remains somewhat wider, and typically bilateral depressions at the site of lacerations become permanent. These changes are characteristics of a porous cervix. If nullipara is such point, after childbirth it's such as line. During the next few weeks, the low segment is converted from a clearly distinct substructure large enough to accommodate the fetal head to barely discernible uterine isthmus located between the corpus and internal os. Cervical epithelium also undergoes considerable remodeling, and this actually may be salutary. Uterine involution. It's very important question. Immediately after placental expulsion, the fundus of this contracted uterus lies slightly below the umbilicus. It consists mostly of myometrium covered by serosa and lined by basal decidua. The anterior and posterior walls in close opposition each measure 4 to 5 centimeters thick. Immediately postpartum, the uterus weighed approximately 1,000 grams. Because the blood vessels are compressed by the contracted myometrium, the uterus on section appears ischemic compared with the reddish purple hyperemic pregnant organ. 2 days after delivery, the uterus begins to involute, and at 1 week, it weighed about 500 grams. By 2 weeks, it weighed about 300 grams and has descended into the true pelvis. Around 4 weeks after delivery, it regains its previous non-pregnant size of 100 gram or less. At the end of the first day, postpartum fundus level is 16 to 18 centimeters above symphysis, and normally its descent not less than 2 centimeters per day. The total number of muscle cells probably does not decrease, and the involution of the connective tissue framework occurs equally rapidly. I pay you attention, not less than 2 centimeters per day. Because separation of the placenta and membranes involves, the spongylia, the deciduobasalis, is not slowed. The deciduo that remains has striking variation and in thickness, has an irregular jagged appearance, and is infiltrated with blood, especially at the placental site. It takes up to 5 weeks for the uterine cavity to regress to its non-pregnant state of a potential space. After pains, in primiparas, the uterus tends to remain tonically contracted following delivery. However, in multiparas, is often contracted vigorously and at intervals and gives rise to after pains, which are similar to but milder than the pain of labor contractions. They are more pronounced as parity increases and worsens when the infant suckles, likely because of oxytocin release. Usually after pains decrease in intensity and become mild by the third day. Lochia. What is lochia? It's discharge after labor. Early in the puerperium, slowing of decidual tissue results in a vaginal discharge of variable quantity. Lochia persists for up to 4 to 8 weeks after delivery. May be different amount, small, moderate, and heavy amount of lochia, and they are different according day after labor. For the first few days, it's lochia rubra. It's made up for mainly blood, bits of fetal membranes, deciduum, meconium, and cervical discharge. After 3 or 4 days, it's lochia serosa. And after about the 10 days, it's lochia alba. It mainly consists of decidual cells, mucus, white blood cells, and epithelial cells. And lochia alba can continue until 6 to 8 weeks after labor. Endometrial regeneration. Within 2 or 3 days after delivery, the remaining decidual becomes differentiated into 2 layers. The superficial layer becomes necrotic and is slowed in the lochia. The basal layer adjacent to the myometrium remains intact and is the source of new endometrium. The endometrium arises from proliferation of the endometrial granular remnants and the stroma of the interglandular connective tissue. Endometrial regeneration is rapid except at the placental site. Within a week or so, the free surface becomes covered by epithelium and fully restored endometrium obtained from the 16th day. Histological endometritis is part of the normal reparative process. It does not reflect infection. At this slide, we you can see information about uterine subinvolution, but it's pathological condition. Before I explain how must be normal involution of the uterus, and if present subinvolution, if happened some problems of uterine contraction, of course it's necessary to treat for prevent postpartum hemorrhage, for prevent postpartum endometritis. Placental site involution. Complete extraction of the placental site takes up to 6 weeks. When this process is defective, late onset puerperal hemorrhage may ensure. Immediately after delivery, the placental site is approximately the size of the palm, but is rapidly decreased, and within hours of delivery, the placental site normally consists of many thrombosed vessels and ultimately undergo organization. By the end of the second week, it is 3 to 4 centimeter in diameter. The involution is not simply absorption in situ. Exfoliation consists of both extension and downgrowth of endometrium from the margins of the placental site, as well as development of endometrial tissue from the glands and stroma left deep in the deciduobasalis after placental separation. The placental site exfoliation results from slowing of infected and necrotic superficial tissues, followed by a remodeling process. Urinary tract. Bladder trauma is associated most closely with the length of labor, duration of labor, and thus so some degree as a normal accompaniment of vaginal delivery. Postpartum, the bladder has an increased capacity and relative insensitivity to intraversal pressure. Thus, overdistension, incomplete emptying, and excessive residual urine are common. The dilated ureters and renal pelvis return to their pre-pregnant state over the course of 2 to 8 weeks after delivery. Urinary tract infection is of concern because residual urine and bacteriuria in a traumatized bladder, coupled with the dilated collected system and conductive to infection. Peritoneum and abdominal wall. The broad and round ligament require considerable time to recover from the stretching and loosening that occur during pregnancy. As a result of ruptured elastic fibers in the skin and prolonged distension caused by the pregnant uterus, the abdominal wall remains soft and flaccid. Several weeks are required for these structures to return to normal. Recovery is aided by exercise. Except for stria, the abdominal wall usually resumes its pre-pregnancy appearance. When muscles remain atonic, however, the abdominal wall also remains lax. Marked separation of the rectus abdominal muscles, diastasis recti, may result. Sometimes necessary surgical treatment of this situation. Changes in blood and fluid changes. Marked leukocytosis and increased level of platelets may occur during and after labor. The white blood cells count sometimes reaches 30, with the increase predominantly due to granulocytes. There is a relative lymphopenia and an absolute eosinopenia. Normally, during the first few postpartum days, hemoglobin concentration and hematocrit fluctuate moderately. If they fall much below the level present just prior to labor, a considerable amount of blood has been lost. Although not extensively studied, in most women, blood volume has nearly returned to its non-pregnant level by 1 week after delivery. Cardiac output usually remains elevated for 24 to 48 hours postpartum and declines to non-pregnant values by 10 days. Systemic vascular resistance follows inversely and remains in the low range characteristic of pregnancy for 2 days postpartum and then begins to steadily increase to normal non-pregnant values. Pregnancy-induced changes in blood coagulation factors persist for variable periods during the puerperium. Elevation of plasma fibrinogen is maintained at least through the first week, so is the sedimentation rate. Normal pregnancy is associated with an appreciable increase in extracellular water, and postpartum diuresis is a physiological reversal of this process. Very important moment, it's changes in breast and information about lactation, about breastfeeding. Anatomically, each mature mammary gland of breast is composed of 15 to 25 lobes. I hope you know it. Each lobe consists of several lobules, which in turn are composed of large numbers of alveoli. Each alveolus is provided with a small duct that joined others to form a single larger duct for each lobe. These lactiferous ducts open separately on the nipple. Of course, I hope that you know anatomy of mammary glands, and I want to show for you how change mammary gland during breastfeeding and structure of mammary glands. Please pay attention on this picture. At this picture. First few days, absent milk. During pregnancy and during first 4 days, present only colostrum. Later, colostrum plus milk. First of all, what is colostrum? After delivery, the breast begin to secrete colostrum. It usually can be expressed from the nipples by the second postpartum day. Compared with mature milk, colostrum contains more minerals and amino acids. It also has more protein, much of which is globulin, but less glucose and fat. Secretion persists for maximum 5 days, usually less, with a gradual conversion to mature milk during the ensuing 4 weeks. Colostrum contains antibodies, it's very important moment, and its content of immunoglobulin A offers the newborn protection against enteric pathogens. And other host resistance factors found in colostrum and milk include complement macrophages, lymphocytes, lactoferrin, and other. Milk. Human milk is a suspension of fat and protein in a carbohydrate mineral solution. Milk is isotonic with plasma, and lactose accounts for half of the osmotic pressure. Essential amino acids are derived from blood, and most milk proteins are unique and include lactalbumin, lactoglobulin, and casein. Fatty acids are synthesized in the alveoli from the glucose and are secreted by an apocrine-like process. Whey is milk serum and has been shown to contain large amounts of interleukin 6. It is associated closely with local immunoglobulin A production by the breast. Prolactin appears to be actively secreted into breast milk. Epidermal growth factors has been identified in human milk too, and because it is not destroyed by gastric proteolytic enzymes, it may be absorbed to promote growth and maturation of newborn intestinal mucosa. At these slides, you can see picture and information about endocrinology of lactation, why it's happen. Of course, it's happened because happen production of releasing hormones, production of prolactin by pituitary gland. Look, letting down is a reflex initiated especially by suckling, which stimulates the hypophysis to liberate oxytocin. The reflex may even be provoked by an infant cry and can be inhibited by maternal fright or stress. It's very important moment. It's such a positive feedback loop. You see that present such a circle. Stimulus. Baby suckles at nipple. Suckling send impulses to hypothalamus. Hypothalamus signals posterior pituitary to release oxytocin. Oxytocin released into bloodstream stimulates milk ejection from mammary gland. Milk is released and the baby continues to feed, and baby feeds and continues suckling, positive feedback, and all of this start again, positive feedback effect. Immunological consequences of breastfeeding, such as I said before, important moment is secretory of immunoglobulin A. This macromolecule is secreted across mucous membrane and has important antimicrobial functions. Much attention has been directed to the role of maternal breast milk lymphocytes in the immunological process of the newborn. Milk contains both T and B lymphocytes, but the T lymphocytes appear to differ from those found in blood. Milk T lymphocytes are almost exclusively composed of cells that exhibit specific membrane antigens, including their LPA1, a high memory T cell phenotype. These memory T cells appear to be another avenue to the neonate to benefit from the maternal immunological experience. Lymphocytes in colostrum undergo blastoid transformation in vitro following exposure to specific antigens. Nursing. Human milk is ideal food for neonates. It provides age-specific nutrients as well as immunological factors and antibacterial substances. Milk also contains factors that act as biological signals for promoting cellular growth and differentiation. Breastfeeding is associated with decreased postpartum weight retention. And at this slide you can see establish the potential protective effect on infants of human milk and breastfeeding. Some positive protective effect. It's sudden infant death syndrome, type 1 diabetes mellitus, inflammatory bowel disease, lymphoma, and all other diseases. Or decrease in incidence and present possible protective effect of some diseases. Present international 10-step and many doctors know about it. It's 10 steps, some steps to successful breastfeeding, and all these steps you can find in different lecture material articles, because in all countries propose involve breastfeeding, propose explain for patient why it's necessary, and help for our patient start breastfeeding correctly. And you can see it on this slide. Women who don't breastfeed may experience engorgement, milk leakage, and breast pain, which peaks at 3 to 5 days after delivery. As many as half require analgesia for breast pain relief. Up to 10% of women report severe pain up to 14 days. Milk fever, puerperal fever from breast engorgement is common. Fever seldom persisted for longer than 4 to 16 hours. The incidence and severity and fever associated with it are much lower in women breastfeed. Other causes of fever, especially those due to infection, must be excluded. Contraception for breastfeeding women. Ovulation may resume as early as 3 weeks after delivery, even in lactating women. Its timing depends on individual biological variation as well as the intensity of breastfeeding. Progestin only contraceptives, mini pills, depot medroxyprogesterone or progestin implants do not affect the quality or quantity of milk. It's if we said about hormonal contraception. Of course, we can use we can propose barrier contraception or chemical contraception, but we can't propose contraceptives with estrogens. Contraindication for breastfeeding in women who take street drugs or don't control their alcohol use, of course, have an infant with galactosemia, have have HIV infection, have active tuberculosis, take certain medications, or are undergoing treatment for breast cancer. Breastfeeding has been recognized for some time as a mode of HIV transmission. Other viral infections don't contraindicate breastfeeding. For example, with maternal cytomegalovirus infection, both virus and antibodies are present in breast milk. And you can see what another. It's hepatitis B, hepatitis C, and the women with active herpes simplex virus. Care of breasts. The nipples require little attention other than cleanliness and attention to skin fissures. Fissured nipples render nursing painful, and they may have a deleterious influence on milk production. These cracks also provide a portal or entry for pyogenic bacteria. Because dried milk is likely to accumulate and irritate the nipples, washing the areola with water and mild soap is helpful before and after nursing. When the nipples are irritated, it may be necessary to use topical creams. Infants should not be permitted to nurse on the affected side. The breast should be emptied regularly with a pump until the lesions are healed, and must be correct latch on. Not only nipple, it must be nipple with areola. Look, present latch. Latch was created to provide a systematic method for breastfeeding assessment and charting. Present special score. And different position of the babies during breastfeeding, which we can propose and show for our patients. Present some drugs. Most drugs given to the mother are secreted in breast milk if it's necessary. And this slide you can see drugs have been associated with significant effect on nursing infants. Present many information about breastfeeding. And at this slide, you can see pathological condition such as galactocelia. Occasionally, a milk duct becomes obstructed by inspissated in secretions, and milk may accumulate in one or more mammary lobes. I must say that it's very painful condition. It may resolve spontaneously or require aspiration. Accessory breast tissue, extra breasts, it's about pathological condition, maybe polymastia, polytelia, but it's extra information. It's not according to the lecture, but maybe it will be interesting for you. Sometimes maybe abnormalities of secretion, maybe agalactia. There is complete lack of mammary secretion, or maybe polygalactia. Mammary secretion is excessive. At this situation, we are try to find why it's happened, especially agalactia, and try to treat this condition. In case polygalactia, we must evacuate milk from mammary gland by pump. And of course, present special care for mother during puerperium. Hospital care. For the first 2 hours after delivery, blood pressure and pulse should be taken every 15 minutes or more, frequently if indicated. The amount of vaginal bleeding is monitored and the fundus palpated to ensure that it is well contracted. I repeat again, 2 centimeters per day, not less. If relaxation is detected, the uterus should be massaged through the abdominal wall until it remains contracted. The addition of uterotonics is sometimes required. Blood may accumulate within the uterus without external bleeding. This may be detected early by detecting uterine enlargement during fundal palpation in the first post-delivery hours. Because the likelihood on significant hemorrhage is greatest immediately postpartum. Even in normal cases, the uterus is closely monitored for at least 2 hours after delivery. If regional analgesia or general anesthesia is used for delivery, the mother should be observed in an appropriately equipped and staffed recovery area. Early ambulation. Women are out of bed within 4-6 hours after delivery. The many confirmed advantages of early ambulation include fever bladder, complications, and less frequent constipation. Early ambulation has reduced the frequency of puerperal venous thrombosis and pulmonary embolism. Perineal care. The woman is instructed to cleanse the vulva from anterior to posterior, the vulva toward the anus. The ice bag it's not used now. Sometimes it's applied on ice bag on the low of abdomen. Don't use, but sometimes it's applied to the perineum. May help reduce edema at that region. Most women also appear to obtain a measure of relief from the periodic application of a local anesthetic spray. Severe discomfort usually indicates a problem such as hematoma within the first day or so, and infection after the third or fourth day. Severe perineal, vaginal, or rectal pain always warrants careful inspection and palpation. About bladder function, I said before. Diet. There are no dietary restrictions for women who have been delivered vaginally. And 2 hours after normal vaginal delivery, if there are no complications, a woman should be allowed to eat. With breastfeeding, the number of calories and protein consumed during pregnancy should be increased slightly. If the mother doesn't breastfeed, dietary requirements are the same as for a non-pregnant woman. And you can see what breastfeeding anti-colic diet. What is it? Time of discharge. Usually time of discharge following uncomplicated vaginal delivery, hospitalization is seldom warranted for more than 48 hours. A woman should receive instruction concerning anticipated normal physiological changes for the puerperium, including lochia patents, weight loss from diuresis, and milk let down. Shortness of breath, of chest pain warrants immediate concern. And you can see what postpartum complication possible. And last part of our lecture is its information about newborn. And present special, of course, it's a patient of neonatologist, but of course we must know about newborn. The newborn begins to breathe and cry almost immediately after birth, indicating the establishment of active respiration. Factors that appear to influence the first breath of air include physical stimulation, deprivation of oxygen and accumulation of carbon dioxide, and compression of the thorax. Sometimes possible transient tachypnea of the newborn. It's again physiological. Sometimes it's possible in newborn period. High negative intrathoracic pressure are required to bring about the initial entry of air into the fluid-filled alveoli. Normally, from the first breath after birth, progressively more residual air accumulates in the lung, and with each successive breath, lower pulmonary opening pressure is required. In the normal mature newborn, pressure volume changes achieved with each respiration and very similar to those of the adult. The breathing pattern shifts from the shallow episodic inspirations characteristic of the fetus to regular, deeper inhalation. And surfactants synthesized by type 2 pneumocytes and already present. Lowers alveolar surface tension and thereby prevents collapse of the lung with each expiration. If happen pathology, maybe respiratory distress syndrome. You can see differences in what happened before birth, what happened how it's happened before birth, and what changes develop after birth. very important score, it's Apgar score. According to this Apgar score, we check fetal heart rate, respiratory effort, muscle tone, reflex irritability, and color. And every sign, every parameter from 0 to 2 points. And we use this score for all newborns. The total score based on the sum of the 5 components is determined first and fifth minutes after delivery. We use this score for exclude or for diagnose asphyxia. And American College of Obstetrician and Gynecologists and the American Academy prepare and release recommendation, use and abuse of Apgar score. I repeat again that we use this score for all newborns. Fetus to newborn, neurological adaptation, thermoregulation, methods of heart loss. You see that present evaporation, conduction, convection, radiation. And what is it? I show it's on this slide. Of course, necessary use care for prevent eye infection, for prophylaxis of eye infection, for prophylaxis of gonococcal infection. We use it after labor and after delivery, and we use some ointment with antibiotics. If necessary, usually we are recommended for mothers use hepatitis B immunization. If necessary, we use vitamin K. This injection is provided to prevent vitamin K dependent hemorrhagic disease of the newborn. Universal newborn screening programs began in the early 1960s, when a test for phenylketonuria could be carried out on blood samples collected on filter paper, and today we use this screening too. And routine newborn care, skin care, umbilical cord care. Loss of water from the Wharton jelly leads to mummification of the umbilical cord shortly after birth. Within 24 hours, the cord stump loses its characteristic bluish-white moist appearance and soon becomes dry and black. Within several days of week, the stump slows and leaves a small granulating wound, which after healing forms the umbilicus. Separation usually takes place within the first 2 weeks, but usually it's happens early. The umbilical cord dries more quickly and separates more readily than when exposed to air. We use different clamps or for clamping umbilical cord. Auxiliary temperature measurement, it's obligatory manipulation. The thermometer should remain in place for minimum 3 minutes, and usually we start thermometry after 30 minutes after delivery. And if temperature is normal, after 30 minutes we start breastfeeding. After 2 hours, we use anthropometry. We measure fetal weight and fetal length, circumference of the head, circumference of the chest. Sometime on the presenting part in the region of the denominator, sometime maybe edema of the tissue, edema of the region. It's a physiological formation because body edematous swelling of the fetal scalp disappears without treatment. It's not no pathological significance. It's happened because present edema at the region of the denominator. In axilla, in the region of the neck, maybe vernix caseosa. If it's preterm baby, vernix caseosa more. If it's overterm baby, usually absent or amount of vernix caseosa less. Newborn has lanuga hair. It's hair on the body, and lanuga more if preterm baby. Stools and urine. Of course, students must know that for the first 2 or 3 days after birth, the contents of the colon are composed of soft, brownish, it's green meconium. These consist of desquamated epithelial cells from the intestinal tract, mucus, epidermal cells, and lanuga, it's fetal hair, what have been swallowed along with amniotic fluid. The characteristic color results from bile pigments. During fetal life and for a few hours after birth, the intestinal contents are sterile, but bacteria quickly colonize the bowel. Meconium stooling is seen in 90% of newborns within the first 24 hours, and sometime later. Newborns first void usually shortly after birth, but may not until the second day. The passage of meconium and urine indicates patency of the gastrointestinal and urinary tracts. Failure of the newborn to stool or urinate after this time suggests a congenital defect, such as imperforate anus or a urethral valve. After the third or fourth day, as the consequence of ingesting milk, meconium is replaced by light yellow homogeneous feces. Of course, in neonatal period present some physiological conditions. One of physiological condition is physiological jaundice of the newborn. It starts usually on the not earlier than on second day after labor. But students will study this topic on cycle neonatology. And such as I said before, present routine screening test. It's phenylketonuria and hypothyroidism by measurement to thyroxine levels or thyroid stimulating hormone, the latter being more commonly used. Thank you for your attention, students. Be healthy.